Okay, so we will start with history taking and examination. When the patient comes in IOPD, we see the patient coming and we note the abnormal head posture. If the patient is having some tilt of the head or face turn or some other chin depression, chin elevation, we note it. When the patient sits on the stool, then we ask the history. So the first thing is asking about chief complaints or the presenting complaints. What is the problem that has brought the patient to us? Which is the problem which is pinching the patient most? You see, unless we ask that specific problem and we solve that problem, patient will not be satisfied. So you may do the rest of the examination and remove 10 defects, but if you do not treat the problem which is troubling the patient, then the patient will not be satisfied. So it is very, very necessary to ask the presenting or the chief complaint. So once patient has told the chief complaint, we acquire more knowledge about that complaint. For example, patient says that I have pain in the eyes. Now we'll ask, is it radiating to the head also? Is there headache also? If the pain is associated with redness of the VN or decreased VN, or at what time the pain is more in the morning or in the evening, is it associated with diplopia or some other problem? So we acquire details of the chief complaint, presenting complaint. Then we ask for any other problem. So maybe patient will say that okay, I have also problem of watering. So this is maybe second problem, third problem, and so on. So we note all the problems, and then we finally ask the negative questions. That means that do you have any, let's say, foreign body sensation, itching in the eyes, or so you rule out the other problems specifically, because sometimes the patient may forget about the complaints, so he or she may not mention it in the complaint. So you sort of feed the patient that this complaint is present or not. So in the last, we will ask all the possible complaints: redness, discharge, watering, etc. So once we have taken the history of complaints, then we ask about the family history. Is there any problem, similar problem in the family? Then past history. Did the patient has any history of admission or any treatment taken or any hospitalization? So is the patient smoker? Diabetic history, hypertension is present or not? Any history of alcohol intake? So these are the things which we ask in the personal history. After family history and personal history, in past history, any drug the patient is taking for any ailment, and then we do general physical examination, and then the eye examination. Now, in the eye examination, we start with the VN because that is the most important thing. So, first thing we will note what is the VN of the patient. We record the VN one by one. So, we cover one eye and ask the patient to see with one eye. If the patient can read all the lines of the Snellen chart, the VN is 6 by 6. If the patient can only read the topmost letter, the VN is 6 by 60. If the VN is less than 6 by 60, we ask the patient how many fingers. We show the fingers either 1 or 2 or 5. We place the fingers 1 meter in front of the patient and write If the patient tells correctly, then we say finger counting or counting finger CF at 1 meter. Now, if the patient is unable to read to count the fingers, then we move the hand in front of the eye, and if the patient recognizes the motion, then we say HM or hand movement positive. If the VN is less than that, then we show the light in the eye and ask the patient whether the patient can appreciate the light. If the patient can appreciate the light, the VN is PL positive. So if the patient cannot appreciate the light and you show it and he or she says that I don't know whether the light is there or not, so patient is PL negative. So this is a complete blindness. So there are other criteria for legal blindness, for example, less than 636 or 6 by 60. So there are different criteria for legal blindness, different criteria for total blindness. Okay, so after we have taken the visual acuity, we assess the other visual functions like color vision, pupillary reaction, then we see the field of vision and the contrast sensitivity. So these are the different visual functions which are included in vision. So after visual assessment, far vision and near vision assessment, then we do the eye examination. And in the eye examination, we have we start from front to back. So first thing is the examination of the lids and lacrimal system. This is called adnexa. So we press on the medial side of the eye, firm pressure with the little finger, and if there is discharge from the punctum, this is called regurgitation positive, and it means there is chronic dacryocystitis. And we have, unless we press on the lacrimal sac area and the discharge comes off, there is no other way of identifying it. So regurgitation test is an important component of the examination. Then we evert the lid and see the conjunctiva. We note any swelling on the lid or any mass on the lid. Whether the lid is droopy is called ptosis, or whether the lid margin is turned in, this is called entropion, or turned out, this is called ectropion. So if there is the epicanthic fold, which is a skin fold present on the medial canthus, so we note all the lid abnormalities and the lacrimal system, and then we come on to the eyeball. So eyeball superficially is covered with conjunctiva, and anteriorly there is cornea. So any corneal problem, any opacity, any defect in the shape like keratoconus, if it is bulging outside or if there is thinning. So better to do the corneal examination with straight lamp, because straight lamp is called straight lamp because it converts the light into a slit, and we can take a cross-sectional area of the cornea and we can see at what level is the opacity. So corneal examination is followed by the conjunctival examination. We note where is if there is a congestion, where is the congestion, is it more around the cornea, which is called circumcorneal congestion. And it is present in three important conditions: corneal ulcer, corneal abscess, acute uveitis, and acute attack of angle cholangioglaucoma. If it is present away from the cornea, that means the conjunctival congestion is more marked in the fornices. This is not alarming. It is usually present in conjunctivitis, whether it is bacterial or viral. So after conjunctival and corneal examination, then we look at the anterior chamber. Is there any cells or flare which indicate the uveitis, anterior uveitis? Then we see the iris color, any patches of atrophy, any new vessels, which is called rubeosus iridis. If there is any atrophic patches, maybe in herpetic uveitis. So then we see the pupil reactions. When we throw the light, does the pupil constrict? And if the pupil does not constrict on throwing the light, then this is called afferent pupillary defect. So if we throw the light on the other eye and then shift it to the eye which is being examined and the pupil dilates, this means there is defect in the afferent pathways. After pupillary examination, then we concentrate on the vitreous, any cells, any flare, any reaction. If it is present, this is posterior uveitis. And after vitreous examination, we scan the fundus. So, optic disc is usually the first one. We focus on it because it is a blind spot, so the patient will not be bothered if we keep the light on for some time also. In the disc, we see the central space which is empty is called cup. Normally 30% of the disc is empty, and 0.3 is called the cup disc ratio. In glaucoma, the central neurons degenerate and the central empty space is enlarged. This is called enlargement of the cup. And the cup disc ratio is said to be increased, maybe 0.5 or 0.7. So the cup tells us that the neurons are dead. The surrounding portion of the disc, which is called the neuroretinal rim, will be thin when the neurons will be dead. So we also note what is the size of the neuroretinal rim. After the disc, we concentrate on the blood vessels and then the macula and the periphery of the fundus. See, the macula is the 5.5 millimeter area present at the posterior pole, and this is a thick part of the retina because there are more cones and rods in this area. The central part is called fovea, 1.5 millimeter, which is responsible for the acute vision, and the most sharp vision is produced at the foveola, which is the most central part of the retina. And when we throw the light with the help of a thermoscope, there is a central reflection, and that is called umbu. So we note the central bright reflection of the ophthalmoscope, which tells us that the foveolar reflex is normal or not. So after eyeball examination, then we concentrate on the ocular motility, ask the patient to move. We move the finger and ask the patient to move the eyes and do not move the head. So we move the finger in 9 positions of gaze. Up, right, this is levo elevation, this is dextro elevation, this is dextro depression, this is dextroversion, levoversion, levo elevation and levo depression. This is elevation and this is depression. And the central fixation, when the patient looks straight forward, this is called the primary position. So this is the most important position because normally we are more concerned with the muscle balance in the primary position. We want to make the patient's eye aligned, especially in the primary position. So after ocular motility, we check for intraocular pressure, the sort of vague idea we can get from this is called tonometry, digital tonometry. So we have applanation tonometer and Schiortz tonometer, which were used previously, but now we have air puff tonometers. So intraocular pressure measurement is necessary. Then ocular motility we have covered. Now we make the examination more detailed in the light of the patient's symptoms. So if the patient is complaining of watering of the eyes, then we will concentrate more on the lacrimal system. Let's say patient complains that I have watering. So watering can be produced by two factors. Either the tears are being produced in excess, there is irritation or an infection, or because of the obstructed lacrimal pathways. In case of excessive production, there will be redness, patient will complain of irritation, and patient will have increased watering. This is called lacrimation. But if the eye is white and there is no irritation in the eyes, then most probably this is because of the obstruction of the lacrimal passages drainage system. And this is called epiphora. So we will see at the punctum whether the punctum is closed. This is called punctal stenosis, or there may be lid entropion or ectropion, which is responsible for watering. And if there is no problem in the punctum or the lid position, punctum is lying perfectly in a position with the cornea, then next step is to do probing at sac syringing. We pass a probe in the lacrimal sac and we see whether the canaliculi are patent or not. So if the canaliculi are patent, the probe will pass through the canaliculus and it will stop at the bone. This is called hard stop. But if there is canalicular obstruction, the probe will not go to the lacrimal sac, to the bone, and it stops in the middle, then this is called a soft stop. So this is about watering. Okay, close the